And let's assume you're on call at 2 o'clock in the morning, and the nurse calls you and says that this baby who's being fed 2 milliliters of breast milk every 3 hours is having 4 cc's yellow gastric residuals. What do you do? Okay, now let's think about gastric residuals. Are any of you still measuring gastric residuals?
No more.
No more. Thank you.
No more.
That's perfect. What about 10 years ago? How many of you were measuring gastric residuals 10 years ago? Everybody. Okay. So what happens when the nurses measure gastric residuals? Okay. So if you're feeding a baby 8 times a day, and the nurse measures the gastric residual before each feeding, that nurse pulls back.
Biopsy.
And there's some food there that might look, some material there that might look a little bit yellowish, maybe a little bit green. She throws that away. Guess what? That baby has been working very hard to secrete acid and to secrete pepsin to try to digest that. And the nurse throws it away.
All enzymes.
That's not necessarily the best thing to do, right? And then each time the nurse pulls on that tube, she could be doing a little biopsy of the intestine as well.
Biopsy.
Well, so from a theoretical standpoint, there could be some problems with checking gastric residuals, okay? Well, here's a little history. The guy on the top here, Dr. Roberto Murgas, was a fellow in our neonatal intensive care unit. And about 10 years ago, he came to me in my office and said, I'm sick of measuring these gastric residuals. I don't know what to do with them. And there's no literature that really guides me in any sensible way. Can we set up a study where we do no gastric residuals versus doing gastric residuals? The nursing staff will never let us do this because this is dogma. This is how we've always done things in neonatal intensive care. But then the lady here at the bottom, Dr. Leslie Parker, she is a professor in the College of Nursing and also is a neonatal nurse practitioner. She was able to help us talk to our nursing staff and to convince them that we should do a study. So we started out with a small pilot study that Dr. Murgas did with about 40 babies and found that there was no difference in necrotizing enterocolitis or any kind of adverse outcomes by not doing gastric residuals. And it also provided some confidence for Dr. Parker to submit a National Institutes of Health grant application for a 5-year grant to study doing no gastric residuals versus routine gastric residuals. And that's what was done. And the conclusion of this study was seen here. The results of this trial suggest that evaluating gastric residuals is unnecessary and may decrease the delivery of enteral nutrition to extremely low preterm infants. Limiting gastric residual evaluation to infants with symptoms of gastrointestinal dysfunction may increase enteral nutrition delivery in this vulnerable population, and this can be translated into evidence-based practice in the care of very low birth weight infants. We stopped routinely doing gastric residuals after this. This was published in JAMA Pediatrics, and I think that this actually changed practice because this guy up here asked the question, should we really be doing this? Can we challenge this dogma?